Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Well, thanks so much for having me. This has been a long process to create these guidelines after a study, of which I'll go through, came out. There was a lot of deliberation about how to incorporate those findings into a screening program. And I know many of you may or may not have been screening for anal cancer, and there were lots of different approaches. So this is the first consensus guidelines regarding approach to anal cancer screening. All right, so no conflicts of interest, our mandatory acknowledgement here. So I just wanted to start with a case to frame it, and people can think about what it is. I didn't do a poll or anything, but a gentleman who is 47 years old, routine HIV care, was diagnosed with HIV quite some time before. It's been undetectable since starting ART shortly after diagnosis, and he doesn't have any comorbidities. In addition to screening for anal symptoms, which of the following is most appropriate with regards to anal cancer screening? He does not need cancer screening as he is under 50. He does not need screening as he is asymptomatic. DARE, or digital anal rectal exam, is indicated, or anal cytology and DARE are indicated. So people can feel free to put answers in the chat and let me know what people are doing or what they think they should be doing for anal cancer screening, and we'll talk about it. All right, so let's talk a little bit about cancer screening guidelines, and then I'm going to go through rationale and then some newer data and our modified approach. So that's sort of the outline of my talk today. I wanted to spend some time just going over this figure from the DHHS OI guidelines. So these are the guidelines for the prevention and treatment of opportunistic infections, and there's a section on HPV. In the past, anal cancer screening really was pending results of ANCHOR study and further recommendations to follow. And some experts say screening with DARE. Now we have a little bit more stronger recommendations. And so the screening algorithm for people, this is for asymptomatic individuals. So screening programs are generally for people who are asymptomatic. If they're symptomatic, it's more of a diagnostic approach. So just for that, a differentiation. So the OI guidelines recommend that all MSM and transgender women age 35 and over, and then all others with HIV, 45 and over, are in this bucket for screening. And then it differentiates into whether you have HRA available. I think this is a really important distinction because there are many places that don't have HRA available or have very limited HRA available. And so if you don't, as you can see, the screening approach is quite different. And one really important piece of information to take away from this is if you do not have HRA availability in your area, you should not be collecting anal samples for cytology or HPV testing at this time. So again, if you do not have HRA, no anal paps. You would simply do and assess everyone in this category for anal symptoms and then perform a digital anal rectal examination. I think many people in primary care don't actually do this on a routine basis, and this is something that I think the hope is that these guidelines sort of normalize as part of our regular examination of individuals. I know in our clinic, for instance, rectal exams are not done as much anymore because we have a lot of self-testing for rectal specimens for GCCT. So actually even looking at the anus, people don't do as much anymore because of that self-testing program. So if they have no symptoms and you don't identify any abnormalities on a good digital anal rectal exam, then you can just go ahead and repeat that DARE in a year. If they have any symptoms or abnormalities, then do a standard anoscopy. So in our clinic, we have a little clear plastic anoscope that we can see what may be causing the problems. Hemorrhoids, a mass, is there friable tissue? And I think this is an area where people are going to get more comfortable as they see more and do more exams, just like a pap smear. People are not comfortable necessarily the first time they do it on a cervical pap smear, but as you see more people and you can see what normal versus abnormal is, then you get more comfortable with that. So importantly, in this group, we're not doing cytology and we're not referring for HRA because there is no HRA available. So what if you have HRA available? This gets more complicated in terms of the scheme. That's pretty simple, although people feel like it's not adequate, but we actually don't know. And I'll get to that in a minute. So if HRA is available, that is preferred. You importantly want to collect your anal specimens, so your pap, before you do a DARE. And that is unlike in a cervical cancer screening pap, where you can put lube on the speculum and then you can collect your cytology. That is not the case for anal samples. There is some interference from the lube and it decreases sensitivity and the adequacy of the samples obtained if you do the lubricated digital exam before the pap collection. So collect the pap, and I'll include a link to how to do that in the EANS guidelines, which is the International Anal Neoplasia Society guidelines. They actually have a link to how to do it. So if there are no abnormalities on your digital anal rectal exam, like you don't feel a mass, then you can go ahead and send those samples off for anal cytology and HPV, and we'll talk about that. If there is a mass, they should be referred for HRA for further investigation. Okay, so next step, when you collect your cytology and you have that swab, are you in a location that is doing high-risk HPV co-testing? Not all sites have access to HPV co-testing. So just as a reminder, even if you do cervical cytology and HPV, your lab may not be validated for doing it for anal HPV specimens. So that is something that you will have to sort out if that is something that your lab that you send these specimens will do. So if you don't have that access, then you just rely on cytology. And just like if you have normal cytology for 3 years, then it's 3 years in a row, then you can go to every 3 years for your anal cancer cytology screening. Essentially, if it's at all abnormal, meaning ascus or above, then they get referred to HRA. So a lot of people say, well, that might be a lot of people. And yes, that might be a lot of people. If you do have HPV testing, then this is the more complicated scheme that it goes through. So even if you have normal cytology and you're getting HPV co-testing is what is recommended here, you can end up with an HRA even in the setting of normal cytology. And this just happened to a patient I screened just a couple weeks ago. Normal DARE, a normal cytology, but had high-risk HPV type 16, so is getting an HRA. And that's because we know that that's associated with a higher risk of anal dysplasia and cancer, progression to cancer. Similarly, if you have ascus, you still assess the HPV results, and if they're high-risk HPV negative, then you repeat the cytology and HR-HPV again in a year. And again, if that's abnormal, then you go to HRA. If you're HR-HPV positive and ascus, you go to HRA. And then anything above ascus, it doesn't really matter, you go to HRA. So as you can see, the endpoint in a lot of these boxes is HRA, which is why people who have limited access to HRA are perhaps a little nervous about this whole program. I brought up the EANS guidelines. So EANS is the International Anal Neoplasia Society. Their guidelines came out just a few months before the OI guidelines, but I want to be just highlight the differences between the guidelines. One that importantly is that they're not specific to people with HIV. They have a table that shows that people with HIV are at much higher risk, particularly HIV, MSM with HIV, and transgender women with HIV. But in terms of the key differences between these guidelines, I think the biggest one is that they do have an option for primary HPV testing without cytology as a screening option. So simply sending it off for HPV testing, which is in cervical cancer screening guidelines through American Cancer Society as an option as well for individuals with cervix. So that's one distinction. And then there is a little bit of a distinction in prioritization of individuals in the setting of low HRA availability. And I wanted to bring this up because of the distinction, but also to talk about how you can operationalize maybe sending people off for HRA rather than this whole group. So these are the NIH OAR guidelines, which are the DHHS guidelines. All of these things in this column, there are data to support through studies, higher risk of anal cancer development. So higher grade of cytology abnormality, we know that. So if you have high grade SIL, so high or, in terms of dysplasia, higher grade dysplasia, HPV 16 is the highest risk one. Smokers, I know a lot of our patients, that's a higher risk of anal cancer. Age greater than 60. And so in the ANCHOR study, the higher age was where they saw most of the cancers. Longer duration of HIV, so greater than 10 years of HIV or any AIDS diagnosis. So that could be a CD4 count less than 200 or other AIDS defining condition. As you can see, Ian's guidelines doesn't go into that specific because they're not specific for people with HIV. Okay, so this is some of the rationale here for why we're implementing anal cancer screening. This is a really nice figure, and I have the PMID for this source, and it's actually also in the OI guidelines because it just really shows how much higher of a risk MSM have. And as you can see by age in the far left-hand corner of this in terms of anal cancer incidence per 100,000 individuals, and really puts it into context, why we are implementing these recommendations for individuals with HIV for cancer prevention or cancer early detection. So based on that, and so the high incidence, as I point out, high prevalence of anal HSIL in people with HIV, high progression rates of cancer from anal SIL in the absence of treatment, and that's data from ANCHOR that I'll show you, and efficacy in treating anal HSIL to reduce progression, that is the basis of these recommendations. So this is the study, the ANCHOR study, which I think we've talked about before when it came out now 2 years ago. So there was a lag in determining these guidelines from this data. But I want to point to the title of this. This is not a screening study. This is a treatment of high-grade anal lesions to prevent anal cancer. So it was not a screening study, and I'll talk about how we got here from this to our screening, but it's a phase 3 trial at 25 different U.S. sites. Our clinic was a site, and really the participants were people with HIV who were 35 and over who had biopsy-proven anal HSIL. To identify these individuals, obviously there was a lot of screening that had to take place for these participants to be able to enroll. And the individuals who were identified with anal HSIL were randomized to treatment arm versus active monitoring. And the primary outcome was progression to cancer in a difference in these two groups. All the participants underwent HRA every 6 months at least, and some more often based on their degree of dysplasia and their lesions. So the conclusions of this study were that adults living with HIV who had anal HSIL, a treatment of that dysplasia reduced the risk of progression to anal cancer, and there was a low risk of adverse events. What you can see in this graph here is that the orange is the treatment arm versus the active monitoring arm. So they were just monitored with HRA, but no active treatment was given. And there was a higher number of participants who developed anal cancer in that active monitoring group versus the treatment group. It's not to say that there wasn't progression of cancer in the treatment group, which is what I want to point out, but it was significantly lower in the treatment group. HSIL treatment did not prevent all cancers. The results may not be generalizable in settings where HRA and treatment performed by clinicians with less training and support. So this may be a lot of settings, right? So this was to get certified to be an anchor HRA specialist required additional training on top of what is required to do HRA in general. So that is important to note. These were very experienced clinicians who were doing the anchor assessments. And obviously, we need more research because this is one big study, but we need more data about how to improve screening algorithms because, again, this wasn't a screening. The primary goal was not to look at screening, but treatment versus active monitoring of people with dysplasia. So just at the recent meeting in Europe at the AIDS conference this year, there was an abstract presented on the effectiveness of different anal cancer screening strategies in people with HIV. And I just include this because we don't all have HRA and we may not have HPV, and so testing, co-testing, but what are the best ways to try to hone in on who needs it the most? And can we use a combination of HPV and cytology? And so what this is looking at the screening strategy on the right, and then the number of people who went to HRAs on the left, and then on the far right is the number of people who went to HRAs. You can see the positive predictive value, negative predictive value. And I want to point out that these are all pretty high, actually. And then we looked at the specificity and sensitivity. What we want to try to address is how can we limit the number of people who need to undergo a more invasive procedure like HRA and really get the bang for our buck with our screening. And what this showed was the approach of HR-HPV with cytology triage or vice versa yielded the highest positive predictive value, and HR-HPV alone actually had the highest negative predictive value. So the number of HRA referrals triggered by screening was the highest in HR-HPV alone, and followed by cytology alone, and the lowest was with combination HR-HPV and cytology. So the combination led to less HRA. So what we did at Madison is actually do a modified approach of the DHHS guidelines because we don't have a 5-day-a-week high-res anoscopy clinic. We're trying to improve our availability by hiring an additional clinician, but we don't. UCSF in context has a 5-day-a-week full-day HRA clinic. We have in the Pacific Northwest, we have 3 high-res anoscopy sites alone. That's it. That's it in the Pacific Northwest. So really not a lot of access. So this is what we mocked up for our screening, and hopefully it's helpful for people who are trying to optimize approach in a setting where you may not have that much HRA access. So we have increased the age from 35 to 45 years of age, and of those individuals, they need to have had HIV for 10 plus years or a CD4 count meter of less than 200. And really that's trying to get at the highest risk folks. From the anchor study, people were over 50 who developed anal cancer. So having a period of time where we're trying to catch people in screening before that highest risk period. Even though we're not going to do the anal cytology for everyone, all adults with HIV should undergo an anal symptom assessment and DARE annually. And so really wanting to get people comfortable with looking and doing the examination so that we know what abnormal feels like, Also, there's a lot of other anal abnormalities that we can identify in patients if we're doing the exam. So if they're not 45 and over with HIV for a long-standing HIV or CD4 count less than 200, you assess anal symptoms and perform a DARE. If there's no abnormalities, go ahead and repeat the DARE in a year. If there are any symptoms or abnormalities, if they're less than 35, then do a standard anoscopy. If they're over 35, go ahead and refer for HRA, or if there's bulky disease present on the exam, refer to general surgery for a formal biopsy. For those who are 45 and over with those criteria of longstanding HIV and a CD4 count less than 200, you assess the anal symptoms and you collect your anal specimens, again, wanting to get the anal pap before the DARE. And then if there are no symptoms, no abnormalities on DARE, you go ahead and analyze your HPV results in cytology, as I'll show on the next slide. If there are any symptoms or abnormalities on DARE, go ahead and refer to HRA. So here is what we do, and this is modified from the OI guidelines, but very similar. Essentially, if cytology is normal, we're still looking at HPV results, like I mentioned before. And if it's high-risk HPV, we go to HRA. And if it's ascus or unsatisfactory, then we have this approach where if it's obviously positive for 16 or 18, we go to HRA and then repeat if other. And then if it's greater than ascus, refer to HRA, despite what the HPV results are. So I just wanted to end with saying anal cancer screening is now recommended. And I was just saying to Brian, I don't know if people were on, that after this came out, there's only been one referral, and it's been from me for HRA based on these new guidance. So I think people are still trying to get used to how to incorporate this into a visit and saying, hey, we haven't done a rectal exam in a while, but you know what? Now we got to do it annually. HRA access is limited to non-existent in some areas, and so screening approaches will need to be modified. And as we get more data about co-testing and really trying to hone in on the highest risk people and how to incorporate HPV testing, I'm sure these guidelines will evolve to try to capture patients at highest risk.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.